whilst we're waiting for that to be in presentation mode, I just would like to acknowledge that I'm coming to the conference today from Ghana land in Adelaide, and I acknowledge the never-ceded sovereignty of Ghana people and all Indigenous people in Australia and their leaders and elders past and present. So this paper, as Sophie put in the introduction, I'm the chair of the Ethics Committee at the University of South Australia, and this emerged out of looking at aged care research applications over time, and just pulling together some of the key elements that we see and some key research and thoughts of how to progress this. Next slide, please. So just to orient us to our context in Australia, I did present this in Portugal, by the way, as well, at the Bioethics 2023 conference, and did drive home how, although it seems almost redundant to specify our aged care context in Australia, it does vary widely across the globe. Again, it's useful to specify the context in Australia, where we have institutional long-term care for almost 20% of the population aged 80 or more, and 6% of those aged 65 or more. And critically, of course, these are people who, by definition of being in residential aged care, need support in managing their day-to-day requirements, and they can't do that at home. So they have some vulnerabilities, and we also have different kinds of spaces in residential aged care, including private living spaces, but also shared communal spaces, which sometimes might be a locality for planned research. So we have to be able to adapt across those different settings for what we want to do. Next slide, please. The kinds of research that we see coming before us, obviously there's clinical treatments and care for residents, but there's also research into the conditions for staff and their qualifications and types of professional learning that they can access. There's research into institutional structures and practices, social and emotional environments for residents, as well as, of course, their physical environments, how residents interact with the wider community, and there's research into particular groups with their characteristics, circumstances and needs. For example, it could be health conditions themselves, or geographical issue, for example, rurality, or group identities across culture, gender and sexuality, looking at how services are adapting and meeting the needs of particular groups. So it's quite a wide range of research spanning the institution itself, its staff, its residents, and obviously these groups have very different capacities and interests. Next slide, please. Our key ethics principles that need to be balanced against risk. We want to make sure that the research is well designed, that it has merit, that the mode of research and research questions and literature are relevant and will actually answer the research questions that are being asked. We need to ensure that the research is just, that it's not, for example, leading to unjust outcomes for particular groups and may be biased towards particular kinds of settings. We need to make sure that the research has some benefit to participants, groups, or communities, and of course that it respects the privacy, dignity, and integrity of the participants and upholds their rights. Next slide, please. Because I was overseas, I've included a direct clip from the national statement in Australia. Again, something which I guess we more or less take for granted as part of our ethics terrain, but is highly variable around the world. And the section on consent just makes the point that part of having respect for human beings is making sure that they can make informed choices, that are voluntary, that have the information they need, that are understood by the people to whom that information is targeted. And of course, that varies, as we've just seen a great example in fact of trying to adapt paediatric care consent to meet the needs of families. Next slide, please. So the kinds of risks that we identify, and I find with HREC, a lot of researchers sometimes resistant to identifying risks because they will argue, but my research isn't risky. But often it's the case, and that because of that's their intention, is not to place anyone at risk, and perceiving that if they do acknowledge risk, well, it'll be a great trouble, or they'll have to adapt or change the research. But, you know, the counter message is, well, you need to actually recognise possible risks and put in place effective plans to manage those risks rather than simply deny that the risk exists. And of course, risks are hugely variable from physical, psychological, cultural, financial, reputational, and they're going to vary according to the vulnerability of the participants' characteristics and contexts. There may be different risks combinations. There's the degrees of severity of impacts. Some risks manifest well after the data collection process has occurred, and some risks are more or less remediable. Can you put the genie back in the bottle? So researchers need to make sure that they acknowledge these risks and assess and analyse the risks and have the plans in place to manage these. And of course, the ethical weight of the responsibilities of researchers goes up as there are rising levels of risk. So I see it as one of the key areas of assessment. Next slide, please. As other HRECs in Australia feature, we have levels of risk, which use an algorithm for an online system at UniSA, which classifies the risk levels according to the researchers' responses. Sometimes, of course, these can change when the researchers acknowledges risk. We have a full correct review when it's above low risk, at low risk levels, with an academic committee review as well as the chair review. And of course, there's others that are negligible risk and are reviewed by the ethics review officer and the chair. So it tends to, as the levels of risk rise, so does the level and of scrutiny and the number of people involved in that process. Next slide, please. And I thought this was a good Aussie illustration of risk. The sort of thing that we are often calculating what we can't see. And, you know, we know that these risks might be out there, but they're not necessarily immediately apparent and may or may not arise. We have no direct way of knowing, but we have to imagine and predict what might happen according to the literature and knowledge of the context. Next. So aged care resident issues affecting informed voluntary consent. In terms of participants, residents, they're there because they have some level of impairment in their functioning. It could be cognitive, intellectual, or physical. They might be taking medications that affect their level of cognitive functioning. They are, of course, dependent on institutional care and living in a dependent relationship to the care providers. So again, there might be risks of wanting to cooperate or being seen to deliver what has been requested of them. So these are the sorts of things that they're managing. Next slide, please. Another one is conflict of interest risks. Sometimes aged care providers who are competing after all in a quasi marketplace and charging fees, maybe for a private provider or a public provider, but they want to validate elements of their care regimes. And of course, research is a key strategy for that purpose. And that can create conflicts of interest when a provider staff are involved in having to select participants. Again, they know the participants really well and their capacities, but they can inadvertently and unknowingly even potentially coerce participation or selectively bias data collection. So these are aspects that have to be managed when we're asking staff or management to be part of recruitment. We have to make sure that participants don't feel that they have pressure to give the answers that are sought or expected by the providers. And the researcher needs to be realistic about identifying and managing these possible risks that impact on voluntary informed consent. Is that element of giving information, but also making sure independent relationships that there is the capacity to be truly voluntary, both choosing to participate and the responses that they give. Next slide, please. So one of the strategies that researchers have adopted has been to exclude participants who have impaired cognitive functioning or don't meet the consent capacity assessments. But one of the consequences of that is that, people may still be able to give views on their experiences, even if their cognition is impaired. They still are able to give feedback on what's happening for them and how they feel about it. So we have to make sure that people are not denied the opportunity to participate in research, but recognise the limits of that. It's, I think, an ongoing balancing act. Next slide, thank you. So Hedge and Eloyo-Sua, forgive my pronunciation, argue that there needs to be a capacity evaluation for people with dementia or acquired brain injury to see if they are capable of informed consent. But even where, all indicators say yes, they do have impaired capacity, they may be able to indicate a choice and show understanding. And they name the 4 key components of decision-making in capacity evaluation as knowing that the person understands, that they know that they have a choice and what those choices are, that they appreciate why they're being asked to engage in data collection, and they can reason about that experience. And of course, all evaluations are situation specific and research specific. It will vary according to what's being asked. And we need to make sure that we have time to assess the person's capacities, and we also work with the family so that there's a consideration of the whole of their context, including their socio-cultural context when it comes to inviting them to participate in research. Next slide, please. So another perspective that I thought is really useful, we tend as researchers to see consent more or less as an event. Once we have consent, we proceed. But in these situations where people have varying capacities, and that may change over time, Dewing 2007 argued for an approach seeing consent as an ongoing process where it involves the researchers learning about the person and their context and their family, learning over time about their issues around cognition, being able to communicate at each data collection point what's happening, revisiting that they're happy to go ahead, and understanding if there have been changes in their health or their cognition, and being prepared to review participation to ensure that it's meaningful for them at each data collection point over time. Particularly, some research projects extend over a few years, and people can have really significant changes in their status over that period. And also making sure that the people are able to receive feedback and understand what happened as a result of the research is another part of our responsibilities as researchers, giving people an understanding of what they have collected and produced by their participation. Next slide, please. So managing the risks of coercion, as I pointed out, that coercion doesn't need to be overt or intentional, but it might just simply be a product of someone who's caring for a vulnerable person, being perceived by that person to have power over them and want to please them. Again, it's an issue of spending time between giving the information about research and then asking them to respond, and giving time to discuss with significant others who can inform this, avoiding using the stuff that person directly relies on so that they don't feel obligated to do what they're asked by that person, being really clear that saying no or stopping at any time is an option, and in finding ways to make it easy for people to say no. And by that I mean people can feel diffident about directly saying no to someone face to face, but by not responding or selecting a card, or either opting out by default or actively opting in, are strategies that help people say no, and making it clear to the participant or their family members or their carers that if concerns do emerge, that research is really willing to hear these and to take them on board. Next slide, thank you. So as I pointed out, there are alternative consent processes, opt-in, opt-out. Opt-out means providing information and including everybody unless they actually specifically say no, and that can be very useful in communal settings where you have very non-invasive or demanding observations, for example, of what is the traffic like in the reception area of the residential home, and having, for example, signs up saying that we are observing the traffic in the entrance area, and people can choose to let researchers know they don't want to participate or avoid going through at this particular period. Another, of course, is the waiving of consent, which the national statement provides well where obtaining consent is impractical, where data is not identifiable and research is low risk, and that people would likely have consented if asked, is the tests that we're invited to. Even if we do use those alternative modes of consent, there's still a need to ensure that there's privacy and security of that data, and that it has that research project has demonstrable benefits and is worth conducting. Next slide. We've also had presentations on using secondary data, and that can be an alternative to collecting data directly from residents. These kinds of institutions often, of course, they have the health records of residents, and staff can also collect data about residents, depending, of course, on what kind of data that might be. But there's still a need for informed consent to share residents' data, if at all possible, because that is still significant. And as I said, researchers can waive consent requirements when already collected data that's been shared is not identifiable, and they can't go back and find those people again who gave their consent in the first place for that data to be collected and the risks that's in this loan. Next slide, please. I'm nearly there, Sophie. So this is the last slide. You know, putting an argument basically for inclusion, so that we have better knowledge and better outcomes for people living in aged care, and that, you know, participation in research and advance aged care clinical institutional care models. So it's worth taking the effort. So I'll stop there. Thank you.
Thanks so much, Elspeth. That was gave me a lot to think about. I mean, this is the other end of the spectrum to what I work in. I work in a pediatric institution, but it's something that we should all be interested in, as it's something that will be hopefully facing all of us in our future, you know, as we journey through our lives. And I think you made a point about the importance of consent being an ongoing discussion. And I think that in later iterations of the national statement, that's been acknowledged as being important. So I think hopefully that's how we're all thinking about consent going forward. It's not just at one thing that happens at one point in time, but it's continuing ongoing. And at the end of the spectrum that I work on with children, of course, that sort of has stood for a while, because children's journey changes as they age and their capacity to understand changes. So very interesting. Thank you very much for, and there's been a lot of chat in the chat, lots of conversations around talking. I think when you mentioned assessment of risk, the chat got a bit hot about including ethicists on HREC committees, and I think there are some HREC committees that do have ethicists included, because I think they'd probably be helping with that deliberation around risk as guided by the national statement, but with some more theoretical, practical examples. So